Please go ahead.
Good evening, colleagues. I'm Dr. Alvin. On behalf of MQL Pharma, I would like to welcome each one of you for today's evening educational webinar. We are really thankful for your time to join us today for this very exciting webinar. Next slide. The theme for today's webinar is changing paradigm of hyperphosphatemia management in CKD patients, and this has been a topic of real interest and high unmet need. We have put together very exciting agenda with the help of stalwart faculty members. As you can see on your screen, we have none other than Dr. Alan Almeida as the program director, and then we have Professor Donald Moloney as the speaker for today's meeting. We have joined this meeting on the virtual platform, so please stay connected. And in case you log out, use the same link. Now, with this, I would like to invite our program director, Dr. Alan Almeida, sir. He doesn't need any introduction. Everyone is aware of his credential. He's from St. GS Medical College and KM Hospital, Mumbai, postdoctoral fellow, University of Columbia, USA, former faculty member of St. GS Medical College, former professor and head of Department of Nephrology. Currently, he is the consulting nephrologist and transplant physician and also section coordinator at nephrology, director clinical research at PD Hinduja Hospital and Medical Research Center. He has several accredited publications and also various society association on his name. And he's also a chairperson for ICMR task force project of CKD. And he has been author of many textbook chapters and also the editorial board member for IJN and IJT. So with this introduction, now I hand over today's proceeding to Dr. Alan Almeida, sir. Thank you so much, sir, for joining to us. And I would request you to take the meeting proceedings ahead. And over to you, sir.
Thank you so much, Arvind. And yeah, if you can move on to the next slide. The topic which is going to be discussed today is something which has changed from the time when I was a student, both in medicine and nephrology. And we have today moderators for breakout sessions from 3 zones of our country. One is Professor Lieutenant P.P. Verma from Delhi, Dr. Santosh Varghese from Vellore, and Dr. Hemant Mehta from the city of Mumbai. Now, Professor Lieutenant General P.P. Verma, he has been the president of the Indian Society of Nephrology in the past. He is presently the chairman of the Department of Nephrology of the Primus Hospital in New Delhi, and he has all these various accomplishments to his credit. Santosh is the professor and head of the Department of Nephrology of India's premier institution, the Christian Medical College, Vellore, which has many firsts to its credit. And from the West Zone, we have Dr. Hemant Mehta, who is a course conductor for interventional nephrology courses, and he's at the Leelavati Hospital and Research Center in Mumbai. So we have 3 experts who will be moderating the various breakout sessions after we hear the man of the hour, Professor Dr. Donald Moloney. He's a professor of medicine, a distinguished teaching professor of the University of the Texas System, Division of Renal Diseases and Hypertension, and Center for Clinical Research and Evidence-Based Medicine at the McGovern Medical School, University of Texas, Houston, Texas. You know, when they asked me to introduce Professor Donald Moloney, I was given a curriculum vitae, and I was wondering how I would go through with it, because they made so many accomplishments. There's so many credits, so many achievements of Professor Donald Moloney. And we are privileged to have him here today to talk to us on a topic of wide interest, because there have been such interesting and encouraging developments in this area. He's going to be talking to us on the paradigm shift in the management of hyperphosphatemia and CKD and the role of sucroferric oxyhydroxide. After Professor Maloney speaks, we will be having a question and answer session, which we will get to after we hear Professor Maloney. I invite Dr. Maloney to take the stage and talk to us on this topic.
Thank you very much for that very kind introduction. I'm going to go ahead and share my screen let's see, share. Today's topic, as you've already been introduced, is changing paradigm of hyperphosphatemia and CKD, role of sucroferric oxyhydroxide. And I'm going to start by describing some of the pathophysiologic underpinning for management of phosphorus. And then I'll spend most of my 40 or so minutes describing the clinical trials evidence that supports the use of this agent as a key element in the management of oral intake of phosphorus and the management of hyperphosphatemia in CKD and end-stage renal disease. I begin by noting that the international consortium of experts in the field have compiled the KDIGO recommendations for mineral and bone disorder. These were from 2019, and these were importantly reflected the knowledge to that point. However, the newer iron-based phosphate binders were only coming into play at that time, so these were not yet fully reflected in these recommendations. Having said that, these recommendations clearly set the goals for the management of phosphorus and the use of non-calcium-based phosphate binders to manage hyperphosphatemia and CKD and ESRD. And that's based on a simplified cartoon here of the pathophysiology of secondary hyperparathyroidism and its consequences in patients with chronic kidney disease. What you can see in the center of this slide is that there is an early signal that increases FGF23 and possibly the FGF regulatory factor Klotho complex that have direct consequences on the normal hormonal modulation of bone and mineral metabolism, both for the bones and for the vasculature and for the response of the parathyroid gland. And this increase in FGF23 that occurs during CKD is predicated on a signal that probably is most likely the increased phosphorus burden that occurs in individuals as their renal function is declining. And this results in a normalization of serum phosphorus level through much of CKD or near normalization. But as CKD advances to near end-stage renal disease and finally dialysis requirements, this ability of the phosphatonins such as FGF23 to maintain a normal serum phosphorus level is overcome and serum phosphorus levels increase, and these signals are all amplified. The net results of these signals is that there is secondary hyperparathyroidism, there is a lack of active vitamin D, and there is a trend to amplify vascular calcification and the cardiovascular consequences of renal failure. And this slide from Miles Wolf's work demonstrates the changes in these key markers of mineral and bone disease and CKD that occur long before we reach the need to implement dialysis in these patients. And so as we think about managing CKD, MBD, we should think about how we manage it most appropriately antecedent to the onset of dialysis, as well as during the dialysis period. And that then brings us to the notion that possibly reducing the phosphorus burden on these patients early on, and certainly when they become hyperphosphatemic, may impact the course of comorbidities that occur during CKD, including cardiovascular comorbidities and even some evidence on the progression of chronic kidney disease to end-stage renal disease. The cardiovascular elements of this are well recognized in clinical medicine, and the mechanisms by which this occur have been studied over the last 2 decades. This is a summary slide from early work by Gia Kelly and her colleagues demonstrating the importance of increased phosphorus and increased calcium on the sodium phosphate co-transporter in epithelial cells that result in a change in the mineral matrix in the vasculature and a change in the expression of these cells to be more osteoclast-like, and therefore the blood vessels become more bone-like. And these are all phenomena that our therapies are intended to minimize and to protect our patients in stage kidney disease and in chronic kidney disease, so that they do not develop vascular disease and have premature mortality and major morbidities. The kinds of morbidities and consequences of CKD MBD are listed here on this slide. They would include renal osteodystrophy, which is the earliest recognized consequence of this disease. That's hence the bone part of it, which is a consequence of abnormal mineralization and results in pathologic fractures and other serious consequences to our patients. We often don't think about renal osteodystrophy because we're so focused on the third of these, which is cardiovascular calcification and other abnormal calcifications such as extraskeletal calcification. But renal osteodystrophy is a debilitating phenomenon for people with late and severe kidney failure. Obviously, hyperphosphatemia is the consequence. As illustrated on the team slides, and there are other endocrine disturbances listed on the team slides. There are other deep pathways where these vitamin D products are necessary for endocrine functions, not only in the parathyroid gland, but through multiple tissues. There are neurobehavioral changes that may be related to the abnormal mineral and bone hormonal regulatory pathways, and of course, compromised immune systems. And if you have renal osteodystrophy, you can even see impact on erythropoiesis. So all these phenomenon are the consequences of unregulated and untreated CKD-MBD, and do speak to the notion that our management of this is important. So management of hyperphosphatemia and CKD, which is a key element in the initiation of this whole process, includes dietary restrictions and dialysis, but these alone in end-stage renal disease are usually insufficient to control hyperphosphatemia, and therefore oral phosphate binders are frequently prescribed. I'm not showing the slide of the frequency, but by the first 6 months of patients on dialysis in the US, more than 80% of patients will require phosphate binders to meet the KDIGO goal of phosphorus control. In cross-sectional observational studies with dialysis patients, administration of phosphate binder therapy has been associated with substantial reduced risks in mortality compared with no treatment, and also with reductions in vascular calcification. In particular, if calcium-based phosphate binders are avoided, there is, in comparison to non-calcium-based phosphate binders, calcium-based phosphate binders are associated with an increased risk of hypercalcemia and vascular calcification. And this has led to the development of multiple different non-calcium-based phosphate binders over the last 2+ decades. So these are the various phosphate binders listed on the right-hand side, some of which are calcium and some of which are non-calcium-based phosphate binders. And I'll have multiple additional slides summarizing some of the findings in these particular binders. An ideal binder, as listed on the left-hand side of the slide, would be something that binds phosphorus in the digestive tract, is minimally absorptive, causes no vascular or cardiac complication, has a high and specific affinity for phosphorus alone and not for other important elements, has a high binding capacity, is non-toxic, and importantly, very well tolerated, reduce the risk if it can be demonstrated of mortality and comorbidities, and could be easy to administer with a low pill burden. And if one can minimize the pill burden as much as possible, that will often translate into very much improved adherence with the medication. And we'll show you some data from a 2-year longitudinal cohort Fresenius trial by Coyne and colleagues on adherence to the medication because of the reduced pill burden with Sucroferric Oxyhydroxide, as well as the European Verified trial that has also measured that. So there are limitations for currently available phosphate binders. If I start with the ones in the middle, I've already alluded numerous times to the potential impact of calcium-based phosphate binders, whether it's calcium acetate or calcium carbonate, on the risk of hypercalcemia and associated progression of cardiovascular disease. And I was involved actually in a randomized controlled clinical trial which demonstrated that in end-stage kidney disease patients in Italy. Aluminum salts have been used for at least 4 decades as a phosphate binder, but there is ample evidence from epidemiologic studies of potential for toxicities, including encephalopathy and anemia as a consequence of the accumulation of aluminum and aluminum toxicities, which remain in the epidemiologic literature, real and important phenomenon. And then there are two, before we get to the iron-based phosphate binders, there are 2 other non-calcium-based phosphate binders that are currently used around the world, the sevelamer-based binders and the and lanthanum as a binder. I will make some comments about sevelamer in comparison to sucroferric oxyhydroxide in subsequent slides where those comparisons are made, because it is generally one of the most commonly used non-calcium-based phosphate binder around the world. So let's talk about the sucroferric oxyhydroxide in a non-calcium iron-based phosphate binder, what it does, what it looks like, and how it compares to the other phosphate binders, including the other iron-based phosphate binders. So on the left-hand side of the slide, you see the cartoon of the molecular structure of the binding element, the oxyhydroxide core, which is where the ingested phosphorus is bound, and then it is shielded from from being consumed by binding other things by the starch and sucrose covering. So sucroferric oxyhydroxide comprises this polynuclear iron oxyhydroxide core, which is stabilized with this carbohydrate shell. The carbohydrate shell is used to preserve the capacity of this core to bind phosphorus. The good news about this particular structure and arrangement is that it operates along the entire GI tract from and with a pretty stable capacity to bind phosphorus in GI tract pHs of 1.2 to 7.5 where it has been measured, and maybe even beyond that, but those are really the physiologic parameters that are useful for our patients. In an aqueous environment, the GI tract, the phosphate binding takes place by liquid exchange between the hydroxyl groups and or water with the sucroferric oxyhydroxide and the phosphorus in the diet. Now, I'll read you a little bit about the typical dosing, and then I will show you some comparison with the binding capacities with other phosphate binders that are currently available for our patients. So the recommended starting dose is 500 milligrams of sucroferric oxide 3 times daily with meals, and this is the typical dose that has been utilized. That would be 3 tablets per day. So serum phosphorus levels should be monitored, and the dose is titrated up or down in increments of 500 milligrams total change per day every 2 to 4 weeks until an acceptable serum phosphorus level is obtained. And in most of these slides, we're going to use that acceptable level using the units that we use here in the US, and I believe you also use in India, 5.5 milligrams per deciliter. Some of the slides have the European millimoles on them, so I'll point that out. This is the KDIGO recommended target for patients with end-stage kidney disease on dialysis. In clinical practice, treatment is really based on the need to control serum phosphorus levels, and most patients respond quite well with 3 tablets per day. In the longitudinal follow-up studies of 6 months, 1 year, and 2 years from Coyne and his colleagues, the average dose of sucroferric oxyhydroxide was approximately 4 tablets per day. So the maximum recommended dose for the clinical trials was 6 tablets per day. And should be noted that there's no metallic taste. The tablets should be broken. It doesn't have to be chewed to a pulp. It just needs to be broken so that the agents are available now to the digestive juices so that when it gets into the stomach, it can start to act. And then it's swallowed as a chewed tablet. It does not, again, have to be chewed to a pulp, and it could even be cut or crushed prior to ingestion if that were something that a patient found more palatable. I have actually tasted this product, and I should note that it does not truly have an metallic taste to it. Now, this is a analysis that Dr. Gut-Kunst reported on a few years ago, comparing the binding capacity of various phosphate binders, both the calcium-based and the non-calcium-based phosphate binders, the 3 calcium-based phosphate binders on the top, and the subsequent non-calcium-based phosphate binders on the bottom. All normalized to a 1 gram equivalent 1 gram dose of calcium carbonate. The calcium carbonate, which is listed on top, has a phosphate binding capacity of 0.75. That's because the tablet is 750 milligrams. And you can see calcium acetate has a slightly lower binding capacity, albeit also a little bit lower calcium load according to balanced studies. Lanthanum is at 1, sevelamer carbonate, an 800 milligram tablet, sevelamer hydroxychloride is also, HCl is also the same, 800 milligrams is 0.6, and ferric citrate on the bottom is 0.64 per tablet. The sucroferric oxyhydroxide in the US and Europe is Valporo. In India, it will be the product you're learning about tonight. Binds, the 500 milligram tablet binds 1.6 times as much as 1 gram of calcium carbonate. And if you look over to the next to the last column, you can see that on average, to achieve a binding of about 6 grams per day of phosphorus that you might find in a typical high protein based diet, that calcium carbonate and acetate require 8 to 9 tablets. Sevelamer carbonate would require 10 tablets per day, and sucroferric oxyhydroxide comes in at just under 4, the kind of level that is seen in most of the advanced clinical trials. So let's look at the clinical trial studies. I'm going to start with the one of the registry studies by Flüge and his colleagues that looked at the efficacy and side effects of sucroferric oxyhydroxide compared to equivalent doses of sevelamer carbonate, equivalent in the sense that they were dosed to achieve a serum phosphorus target. So this is a randomized controlled clinical trial that was used to identify and describe this medication in the early stages. And this is the trial design. So there were initial run-in period of 24 weeks and patients who were either given sucroferric oxyhydroxide or sevelamer carbonate. At 24 weeks, there was a small group who were reduced from the intended therapeutic level of sucroferric oxyhydroxide to a low dose. These were then ultimately withdrawn after a 3-week period of time. And this demonstrated that in these patients, those who were managed with the sucroferric oxyhydroxide, that when they were withdrawn, the well-achieved phosphorus levels that were observed in the first 24 weeks were obliterated when they went back to their non-phosphate binder treatment. And then the trial was extended with a small group of crossover patients, no crossover patients, but extended for sevelamer carbonate and for sucroferric oxyhydroxide. The medium, large, and higher group were added to that, and this was extended up to a year plus a 3-week washout period. So 52 weeks of therapy and 3 weeks post. And these are the data from that trial. On the left-hand side, you can see that with both the sucroferric oxyhydroxide and sevelamer carbonate, that they achieved the target reduction in the serum phosphorus level, such that one could say that any changes that one saw in the trial were not due to inadequate treatment with one arm or the other. And then what you see in the middle is that there was achievement of the KDIGO upper limit of phosphorus. This is a mean, so there were some patients that did not achieve this, and we will look at a post hoc analysis of this study to determine what characteristics might have identified prior to treatment those who might be more resistant to the effects of phosphate binders and to the effective reduction in serum phosphorus level. And then on the far right, you can see the mean number of tablets that were used in this trial. And what you can see is that initially there were 3 tablets for the common dose for the SO group, and sevelamer carbonate was 8 tablets. During the mid phase of the trial, it was 4 to 10, as one would have predicted from the Goodkunst analysis. And then at the conclusion of the trial, it was 3.3 and 8.7 as the patients were transitioned off the trial observation period. So it persisted, this lower pill burden persisted. They also looked at some important side effects, potential side effects, and this will also be evaluated in the VERIFY trial that was conducted in the EU specifically to look for side effects such as iron accumulation and other consequences that theoretically might occur with these two treatments. And what you can see here is that neither with the SO or with the sevelamer was there any iron accumulation during the time of this 52-week trial. So this is a phase 3 trial, so it was a randomized controlled clinical trial for understanding both the treatment and emergent adverse events. Treatment-related emergent adverse effects were more frequent with SO compared with sevelamer carbonate. I'm going to show you that in just a minute. The majority of these were mild transient diarrhea. Discolored feces were also seen, as one might expect with an iron product. Constipation and nausea were more frequently with the sevelamer carbonate arm. The safety profile for sucroferric oxyhydroxide was similar in the groups of patients studied, and all cause of discolored feces with sucroferric oxide occurred during the phase 3 transition phase, titration phase, so early on in the trial, and none led to withdrawal. Diarrhea was generally very mild and did not require withdrawal from treatment as well. Now, I did say I was going to show you those data, but I'll show you the data on the VERIFY trial that look at diarrhea as well, which I think is just as illustrated. But this is a post hoc analysis of this particular trial that was published some years later by Kovic and colleagues, and demonstrates that there was a difference that you could observe in the patients who achieved phosphorus control versus those who did not. One difference was that those who did not achieve the control measures, which in this case was at a serum phosphorus level of less than 5.5, had a higher starting serum phosphorus level. And you would say, well, maybe that's just because they had a longer way to go. But if you look at the line just below that, the reduction in serum phosphorus level was much more prominent and greater in those who achieved control, and really not very substantial in those who did not achieve control. And this was also observed to be predicted by being somewhat younger in age and having a higher BMI, and maybe the higher starting serum phosphorus level did indicate a trend towards being less adherent with the medication. That was not reported in this post hoc analysis. So let's look at the real world experience, because I think these will be instructive. This real world experience, I'm going to show you this 6-month analysis, and then the 2-year analysis. There was both a 1-year and a 2-year analysis, which very largely reiterate what was shown in the 6-month analysis. And these are data that are drawn from a large dialysis provider's electronic medical record and their pharmacy system, the Fresenius dialysis system in the US, which dialyzes about 50% of our dialysis patients here in the US. And they have a mail order pharmacy. And so one was able to exploit this pharmacy information to look at how well sucroferric oxyhydroxide fared in this real world population. So I'm going to read the conclusions, and I'm going to show you a little bit of the data. The sucroferric oxyhydroxide demonstrated controlled serum phosphorus levels with a low mean prescribed number of pills. I should say that these changes to SO were determined and driven by the clinicians, and the patients who were largely recruited to this cohort, so to speak, were those who had a poor control on antecedent use of phosphate binders. The proportion of patients with serum phosphorus level of less than 5.5 increased from a measly 15.6% at baseline to 30.4% at 6 months. And it was well received at 3 months and 6 months. So let me just show you some additional data. These are just the data showing the comparison between the achievement of phosphorus levels and the pill burdens that were antecedent to the change from another phosphate binder, in this case, Velamir calcium acetate and lanthanum carbonate. In each case, the achievement for all phosphate binders and or each individual phosphate binders was less than 15%. And then at 3 months and 6 months, it achieved up to 30% success. And what you can see on the right-hand side, the number of pills was reduced from an average of around 8.8 to about 3 to 4 pills per day during this observational period. Now, in discussions subsequent, and I was party to this discussion, we thought that it would be really good to look at a more long-term evaluation. And this study was designed to really try to match something that might be akin to propensity scored analysis of a observational epidemiologic study. In this case, everyone in this trial, or this observational cohort, was prescribed, switched from a phosphate binder largely, and then prescribed SO. And then after a period of somewhere between 30 and 90 days, there was a proportion of these individuals who were switched to a non-SO phosphate binder therapy, either because they achieved control with the sucroferric oxyhydroxide, or they were intolerant, or they just couldn't afford it, or some other reason. So the reasons for the switch were not specified, but it was not simply because of intolerance, but there were often just choices in terms of preference of patients. And what you can see is that then these patients were either followed in the non-SO group for up to 2 years, versus those who were maintained on the sucroferric oxyhydroxide therapy for a full 2-year period. And these are the results by quarter of the achievement of phosphorus control. What you can see clearly is that phosphorus control was inadequate antecedent to the initiation of the SO. And then what happened is that the patients who were on SO and switched back in the brown bars here achieved a little bit better, because now they were in clinical observation, but did not maintain as good an outcome as that observed in the similar type patients who selected to continue with the SO therapy, where the achievement of the goal of serum phosphorus level of less than 5.5 was achieved and this is the way this was measured, was achieved in excess of 40% of patients. And this success with control of phosphorus was continued through a full 2-year period. What you can also see on the bottom is the serum phosphorus levels of the two groups. It was the mean was at the end of the trial was 5.98 for the SO group, and the non-SO group it was back up to 6.34. So there was some control in some, and there was a substantial difference in the number of phosphate binders that they were achieved were prescribed and were taken in this real-world experience. Again, this is real-world experience. These are not selected for a clinical trial. These are our average type of patient. I also choose to show you these because these are the real data, and clearly what you can see is that the SO group achieved a higher level of phosphorus control, as I've already indicated. There was no difference in the serum calcium levels in the group, and in this observational study, there was really no impact, significant difference in impact on the PTH, intact PTH, albeit it seemed to trend in the same direction with both. The other safety measure that is always of concern was what happened to the hemoglobin and the iron studies. On the bottom, you can see that in this, again, real-world experience, there was no change observed in the serum ferritin levels. The ferritin levels started pretty high to start with, but they did not change. There was a very mild change in the transparent TSAT transparent saturation, but not clinically significant. It is statistically significant in this very large trial, and the hemoglobin levels did not change significantly. Now, the verified trial from Europe will look at these same parameters again. And the interesting thing in this is they also looked at the hospitalization rates, and for reasons that have not been explained, those who were continued on the SO versus those who were switched to other phosphate binders. And remember, both groups were being maintained on phosphate binders to achieve an adequate control of phosphorus, albeit there was better control of phosphorus in those who were maintained on sucroferric oxyhydroxide. And I should also note that these were limited to monotherapy patients only, so there were not any crossovers or dual therapies. And what you can see is that there was a reduction using multivariate models to account for differences in diabetes status and smoking and other factors that might influence cardiovascular and other forms of hospitalizations, that there was a reduction in long-term hospitalizations and in all hospitalizations in the multivariate model. The importance of a greater than 24-hour hospital stay is that some people might be hospitalized for a very transient vascular access repair or something like that, which is often less than 24 hours. And this is just summarized what I just said, so I'm going to switch that as continue in the interest of time. I've left this next slide in. This is a small study that was also observational, but I want to, and they found basically the same kinds of findings as I've just reported to you from the previous 2-year observational study that was much larger in the US. This is in Europe, of course. And but I do want to point out to the last 2 bullets here that they observed a improvement in the cholesterol level and in the lipid profile. And there are other reports, both from epidemiologic studies and from some of the clinical trials, that demonstrate some improvement in lipid profiles that may be observed in patients treated with SO, albeit this has not been fully characterized. The other thing that is of interest is that the albumin levels remain very stable. I didn't show you an observational study in peritoneal dialysis patients, but in peritoneal dialysis patients, albumin is more difficult to maintain because of the losses of protein sometimes in the PD fluid, and nutritional status in these patients is very critical. And what Dr. Ken Kalantar-Zayedeh demonstrated in the trial, that in the PD patient population, albumin levels actually improved with sucroferric oxyhydroxide, and this would support the notion that this agent does not interfere with important nutritional goals and the absorption of proteins and other nutritional agents. Again, I'm going to skip that. So I want to turn to the VERIFY trial and then one other trial and end with that. So this is another real-world trial. It's a non-interventional prospective multi-center cohort study conducted in 7 European countries, principally to evaluate the safety and effectiveness of sucroferric oxyhydroxide in dialysis patients with hyperphosphatemia in routine practice. The safety outcomes included adverse drug reactions and changes in iron-related parameters, and the SFOH effectiveness was evaluated by changes from baseline in serum phosphorus and percentage of patients achieving target levels. And these will be using European units. This was the design of the study. There was the actual prospective trial was a 6-month free trial, retrospective analysis, and then a 36-month period. In the second phase, there were patients who were already in an observation period, but not as part of this trial, that were then included so that they had 42 months on sucroferric oxyhydroxide. And these are the results. What you can see is across the top that there was achievement of a improvement in serum phosphorus levels down to an average of about 5.3. And the little bar on the bottom is the percent change from baseline. So these were patients who were not as severely abnormal in their serum phosphorus levels as the prior trials that I demonstrated to you, but did achieve the target control with this agent. What you can also see is that the proportion of individuals who achieve either, I said these were in European units, but actually these are the North American units, serum phosphorus levels of less than 5.5, the dark blue bars, or even better yet, serum phosphorus levels of less than 4.5 were substantially increased in the subjects that were treated with sucroferric oxyhydroxide, and this was sustained over the full observation of the trial. Now, diarrhea is really the most commonly reported adverse event. On the left-hand side, you can see the frequency of either missing data, which is light blue, or severe, which is what we should focus on, moderate or mild. In the first column, which is the first month, that's expanded, and you can see that most of the events occurred in the first week, and most of them were mild or moderate, and there were very few severe, and that the reported episodes of patients who were maintained on this agent was substantially reduced as the weeks went ahead. And what you can see is the majority of patients reporting their first episode of diarrhea lasted less than 1 week or 1 to 2 weeks, and very few of them were persistent or long in duration. So this is a common side effect. It does cause some looser stools that are sometimes classified as mild diarrhea. They were careful to try to make the definition correct, but some patients continue to think looser stools are a diarrhea. Nonetheless, there were no patients that were withdrawn from this agent on the basis of the observed changes in stool habits. This is now the iron parameters, and what you can see here again is that the serum ferritin on top, the TSAT in the middle, and the hemoglobin levels on the lower end did not change throughout the entire period of observation from baseline through the last clinic visit, and I will not belabor those. This is a measure of adherence in the full cohort of 1,322 individuals, and what you can see is that adherence with this agent by pill counts and by the survey method that's described here in this paper was either very good or very adherent, adherent or very adherent, pink and blue bars, in over 70% of the patients. If you recall your own experience with phosphate binders in your patients, this is a pretty extraordinary adherence to treatment that they are, on average, taking with every meal. So it's not a once-a-day treatment, but it's with each meal. This Spanish trial is much smaller. It's a similar type of design. I'm going to just show you it because it, again, shows very similar type of results. And here again, you can see that from baseline to final observation in this observational study, there was excellent achievement of phosphoruses of less than 5, in this case, milligrams per deciliter, in over 75% or 45% increase from their baseline observation. And adherence also increased substantially to greater than 50% in this clinical prospective cohort observational trial. Now, this is a very complicated slide, and in the interest of time, I'm not going to read it in great detail. I do want to call your attention to this review by Stuart Sprague and Jürgen Flöge from Expert Opinions in Pharmacotherapy, just again outlining all the different binders. And what you can see is that the potential advantages with sucroferric oxyhydroxide that they have listed is: 1, no calcium exposure, low pill burden, binds strongly to phosphorus over a wide, or phosphate over a wide pH range, low iron release and absorption, and no effect on viability of vitamin D antagonists. And most medications, albeit it is recommended that some medications be taken independent and in time-wise from this agent. There are the GI side effects that I alluded to. You can look at the others. Again, in the interest of time, I'm going to move on. And I'm just going to summarize and then open it up for questions. So sucroferric oxyhydroxide has several beneficial attributes that differentiate it from other phosphate binders with respect to treatment efficacy, safety and tolerability, pill burden, and convenience of administration. In terms of efficacy, SFO displays a high phosphate binding capacity, resulting in effective serum phosphorus control with a relatively low pill burden. SFO has a favorable safety profile that is mostly well tolerated, allowing patients to remain on treatment and achieving long-term serum phosphorus. I did note that it causes loose stools or diarrhea in comparison on that previous chart to sevelamer, which is more like, and in the clinical trials, is more likely to cause constipation. Sometimes patients would prefer to have a little bit of loose stools rather than constipation. That's patient preference. Minimal iron absorption, no evidence of iron accumulation, and I believe that this is a powerful advantage to this agent because you can separately manage iron from this management of phosphorus. And if your iron is at target levels, you don't want to have to switch to another phosphate binder. In this case, you wouldn't have to because there's no real iron absorption. And it's effective in maintaining controlled serum phosphorus levels with a significantly lower pill burden, leading to better treatment adherence than with other agents, including sevelamer carbonate. And with that, I will thank you for your kind attention and open it up to questions in the chat.
Thank you, Donald. I invite now the three moderators from the various zones, Professor Lieutenant General P.P. Verma from Delhi, Santosh Varugis from Vellore, and Dr. Hemant Mehta from Mumbai. And we will together field, or rather ask Donald Maloney questions regarding this new entrant, the new entrant on, or the new kid on the block. And we had to start off with two questions in the chat box. One was, how long should patients take sucroferric oxyhydroxide once it is started? I think you did mention one of the studies which switched over, but that we did not know what were the reasons. But would you advise it perpetually, or would you say take it for a short time and then switch to the more conventional phosphate binders?
So the clinical experience that's reported in the studies does speak to this question to some degree, because many of these patients that were switched were already showing inability to control phosphorus. Now, some of them are naive to phosphate binders, but many of them were not. So once one achieves a target phosphorus level with the good tolerance of the medication, I think it does not, it's not a benefit to the patient to try to switch them to something that they may now experience intolerance. There's no advantage to achieving a level and then going to another treatment where the success that you've already maintained, it may not be reiterated. The goal is to keep the phosphorus level well controlled forever. So the patients that I have on sucroferric oxyhydroxide in the US, and I have a fair number of them, I don't use any calcium-based phosphate binders, and I've switched a number from one of the others to this agent over the last number of years. I keep them on this agent. And again, one of the real advantages is that they really enjoy only having to take one per day. Again, I reiterate, they don't have to chew it to a pulp. There are some phosphate binders that you have to really chew very rigorously. You just have to break it. It doesn't have to even be done by chewing. It can be done by other means. And so it's very well tolerated. I keep my patients on it forever if they're successful.
That's great. Any of the other moderators had any other question with you?
Donald, yeah. Wonderful talk. I enjoyed it and it was very clear. Just asking you that what percentage of your patients are on sucroferric oxide versus sevelamer?
Okay. I would say that it's about 50-50 for those who are on phosphate binders. I still have a substantial number who are on sevelamer carbonate because they've just been successful with that, especially those who are pretty good about diet and don't have to take. I've had some patients that have required 6 tablets per meal or 18 tablets per day plus 2 or 3 with snacks. So 20 tablets a day of sevelamer carbonate. Those are some of the first ones that I attempted to switch and have successfully switched them to much lower doses of sucroferric oxyhydroxide. Yes.
I just wanted to know, this drug is approved by FDA almost 8 years back. And even in European, it was approved almost 7 years back. And the drug is so good, all the benefits you have mentioned, why it has not become number one drug?
Well, actually, it wasn't released in the U.S. until it may have been FDA approved, but there was a marketing issue and releasing, so it's not quite set 8 years. But I won't argue that it's been a long time. So I don't really know the answer to that, except habits die hard. And in the U.S., there is still about 30 to 40% of patients that are being treated with calcium carbonate. And the other thing is that phosphate binders are now in the quote unquote bundle, so that the dialysis providers have to basically pay for the phosphate binders. And sevelamer now is generic, and so it's a little less expensive. So there is an economic incentive for them to use sevelamer carbonate. Maybe not a great answer, but it's a very interesting question.
Hi, two questions.
Yeah.
Professor, would you say that this drug is a specific drug of choice for those with difficult to control phosphate, or would it be just as similar to sevelamer? That's first question. The second question is, do you have any experience of giving combination of phosphate binders with sucroferric oxyhydroxide plus sevelamer, for example? Like sometimes we have to combine sevelamer with calcium acetate. So that's our question. Thank you.
Okay, so I should not leave with you with the wrong impression. This is not simply for patients who are difficult to control, but I can tell you that in our clinical experience as this rolled out in the US, those were the first patients who were tried on this. So at this point, this is often one of my first line therapies, maybe my first line therapy for someone who's naive to phosphate binders. Many patients come to me with have been managed by someone else during CKD, and we still have our residents using sevelamer in the hospital, and that's another limitation to spreading the good word here, so to speak. So it's not limited to people who are difficult to control, but that is what our initial experience was, because that's the people we choose to try to do something different. But now it's clearly also been demonstrated for us in our clinical experience to be very effective as a first-line treatment, as a monotherapy. There are people who use there's not a lot of studies on this. I actually did something with the Fresenius database looking at dual therapies, and the most common dual therapy in that database, and so we published this in Kidney 360, I think now 2 years ago, it's been a long time, was with sevelamer carbonate. And so what was observed was that patients were on high doses of sevelamer carbonate in excess of 3 to 4 pills with each 800 milligram tablets with each meal. And then they were added by their clinicians, the US form of sucroferric oxyhydroxide. And the result was twofold in this cohort. There was an observed improvement in the phosphorus control, substantial improvement in those getting under 5.5 milligrams per deciliter. And there was a reduction in the total number of pills. So they added the sucroferric oxyhydroxide. They did not stop the sevelamer, but they were able to reduce the dose of sevelamer carbonate substantially. Now, one of the questions that always comes up, and if you do that, is do you give them both together, put them in a handful, and everyone swallows at the same time as they start their meal? And no one knows the answer to that question. Generally, if I have a patient that is, for some reason, on that strategy, I'll advise them to take one at the start of the meal and then one at the conclusion of the meal, so that there's no science to that. So however it's given, I think that's what the experience shows.
There are a couple of questions in the chat box, both pertaining to the iron metabolism. So one asks whether is there any meaningful effect of SFOH on iron metabolism? That's one. I think you already did mention in your presentation that there isn't anything significant which gets absorbed.
Right.
But there's another, when I use the word significant, there's a question which comes up again in the chat box. Is there any problem if we give this drug to patients with normal target hemoglobin who have got an iron overload? So you got hyperphosphatemia, normal hemoglobin, and have got the iron parameters on the higher side.
Yeah. So that's an interesting question. There is not a lot of evidence on that specific subpopulation. There is clearly the clinical trials, and I didn't show you all the early clinical trials, demonstrate clearly that there is very little iron absorbed over long periods of time from this medication. And that was one of the design efforts that was made in designing it in the first place. There is also some people have suggested that the evidence might support the notion that if you are clearly iron overloaded, there may be a reduction actually in iron absorption with this medication or with any other medication as well. So I think that the bulk of the evidence would support the notion that this is not going to be a problem with iron overload in patients. If you live in a litigious environment like we do in the US, you might say, well, maybe I'm going to avoid all iron products in that unique population. I wouldn't argue against that, but there's no evidence to support the notion that this will be a problem in that patient population.
That's good. And another question in the chat box is, there are reported interactions with levothyroxine, doxycycline, and cephalexin, which have been mentioned. So what is your take on this?
So I think that what is not generally appreciated is that probably all phosphate binders have interactions with drugs and bind some of them. It's been well studied in the newest agents that are now coming out, the two new iron agents. To look at that, the FDA required that they look at these. And in those patients, I think one has to consider a strategy to have the medications, those potentially interfered with medications taken at a time that is a number of hours separate from the original recommendation was 4 hours. I think 2 to 4 hours would probably be adequate to still maintain your doses. But if you have someone on levothyroxine, for instance, and they're on a stable dose of SFOH, then you could check their levels and make sure that you don't have to change it. I think that's still doable. But I would probably administer the levothyroxine at least 2 hours after the administration of the binder.
There's one more question in the chat box. If the loose motions are of a moderate degree and forces the stoppage of the drug, whether we can re-challenge once it settles.
Yeah, so people, that has not been reported in the studies that I showed you, but in experience, people have tried that and have had some success. My own take is that if I'm having a problem, I will give a holiday, so to speak, and then I'll re-challenge with a slightly lower starting dose. So instead of 3 tablets a day, 500, I might do 1 tablet with 2 of the largest meals, so 1,000. And I've had some anecdotal experience. You can take that from whence it comes. It's just a limited experience, so I haven't reported on it. I haven't actually tracked it, but the people are trying that. So I don't think it's unreasonable, especially if it's moderate or mild diarrhea.
We have another question of your phosphate binder polytherapy. How frequently is it required and what would be the combination?
How frequently is combination therapy required?
Yeah.
I don't know the data on frequency. I know that it is not that common in the US. So if you look at, again, these large databases of prescription pharmacies, it's probably far less than 20% of patients are on combination therapy. I would, and even less than that. So it is not that common. You still monitor in the same fashion in terms of side effects and effectiveness in lowering phosphorus. My suspicion is that for many of your patients who eat more of a vegetable-based diet, there's a little less of a phosphorus burden. And so you might be able to achieve with monotherapy, and you probably don't need to think about combination therapy as frequently. But it could occur. I mean, it doesn't occur very commonly, even in the high meat intake diet of North America.
Yeah, there's, I think we just would have learned. Yes, Hemant?
Yeah. Donald, one question from me. We have several occasions when we have not only high phosphorus but low calcium. At that point of time, what would you recommend? Just treat phosphorus with SFO and hope that calcium will come up as phosphorus come down, or combine it with a calcium-based phosphate binder also, or just give SFO with active vitamin D? What would be your choice?
Yeah, I would take the last choice because as long as, in clinical studies that have looked at this, when you give oral calcium to these patients, it doesn't improve your serum calcium level much. It's very marginal. It does go to calcify soft tissues. So I still avoid that. If it's really low, that's a problem, and you scratch your head and you try to get around that. If they're asymptomatic, it buys us some time. I would guarantee, however, that they have at least 600 to 800 milligrams of calcium in their diet per day. And there are many people who might not, and if they're largely vegetarian and they avoid milk products, they may not. So in that case, you could give a little bit of calcium, but I wouldn't use it as a phosphate binder. But clearly, I would exploit vitamin D, and I would try to lower the serum phosphorus level as much as possible.
And at what level of CKD?
We'll have to wind up.
Okay.
Okay, I just got I'm using my prerogative as the program director to ask this last question of Donald. Why is sucroferric oxyhydroxide not used in the non-dialysis CKD patient?
Well, it's not used in the non-dialysis CKD patients because the FDA in the United States, at least in our environment, it probably should be considered for that, and that there are some good clinical trials evidence to support the notion that it would be beneficial to try to correct this problem earlier on. But in the US, the FDA has not approved any phosphate binders in the CKD period because they're not convinced yet that there's enough evidence to support their non-renal effects, such as cardiovascular, in the CKD population. That needs to change. I think there's clear evidence that it's beneficial, but it's a problem. I do prescribe these in the CKD period off-label, so to speak, and I'm not supposed to speak about anything off-label, but it is my choice as a clinician to use these agents if they're FDA approved for any indication. And so I will potentially use that, but the FDA has not approved them for CKD. None of the phosphate binders, in fact.
Okay. Has there been any trials on in this group?
I do believe that there is an ongoing trial right now, but I'm not sure of that. I'm not involved in that particular trial.
Great, Donald. It's been wonderful hearing from you. And whereas we are heading to bed, you're getting up for an active day ahead. It's great to hear from you, and I know that you would have loved to have been here amongst us, but at least in the spirit, we are together. So all the best to you, and thank you very much for your excellent.
Thank you. I look forward to when I can visit personally. I have been to India many times, and I always love to travel to various places in India. So there's an opportunity. I'd love to come meet with some of you directly and talk about these issues and the broader spectrum. Again, thank you very much.
Thank you very much. And now I hand over to the moderators of the three groups, Prem Verma for North Zone, Santosh Varugis for South Zone, and Hemant Mehta for the West Zone. Over to you, so that we can break out into our various zones and continue the discussions.
to the tune of 800 milligram, 8,000 or even more. And at that point of time, the cost also is a big issue. And we can definitely try the newer sucroferric oxide.
Thank you, sir.
But it's only cleared in the dialysis population. That is, FDA has cleared it only for the use in the dialysis population. That is, sometimes we do have patients who have got a very high phosphorus level who are still not yet started on a dialysis program.
What does generally everyone feel? Agree with sir, disagree, or partially agree?
We have been using this drug for the difficult to control hyperphosphatemia. And along with, we have patients with hypocalcemia and hyperphosphatemia. So we don't use a full dose even to start off. We've been using 500 mg twice daily, along with maybe a calcium-based phosphate binder. So that some calcium can go up along. Sometimes, occasionally, we still use vitamin D analog also. And diarrhea has been a problem, and what we have done is we have discontinued the drug for those patients who have been unable to manage the diarrhea, but we have not rechallenged that. So we have a few patients who had diarrhea, maybe less than 10%, whom we had to stop this drug.
Anyone else wants to tell us about their experience with the drug and where they've used it?
I have used it, like I'm Dr. Manjunath from Bangalore. Hi, sir. I have used in around 10 to 15 patients as a primary drug for patients who are CKD who are initiated on dialysis. And some patients whom the phosphorus was not controlled with sevelamer because of increased pill burden. So as a primary drug, I find it good because the amount of drug which is required, like it binds to around 260 milligram of phosphorus, 1 gram of tablet. So around 400 milligram per day can be taken care of with 3 tablets. So this is a significant benefit of the drug, and it's hardly any part of the drug is absorbed. So there is no fear of toxicity. So probably patients who can afford this drug can significantly reduce the pill burden, because many of these our dialysis patients, as you are aware, will be on many of antihypertensives and many other drugs which they will be taking. Probably reduction in number of pills will make a significant difference in their and many of them are on twice a week dialysis. I don't know how it works in other settings. So most of the patients are on twice a week dialysis. So for them also, this drug is significantly helpful in reduction of hyperphosphatemia.
Hi, sir. I'm Dr. Subramanian from Trichy. I would just like to share my experience. I have been using this drug as first-line therapy for some of my hemodialysis patients as de novo therapy, and I find that it works well. The reduction in serum phosphate level is good. But what I find is we cater to a low-middle economic class of patients. So the cost is the only prohibitive factor. Otherwise, it's a wonderful drug, I think.
Sir, I'm Ranjini from Chennai. Hello. My experience with the drug is also quite thin. I have used it around 6 to 7 patients on dialysis. Actually, I didn't have to use that thrice per day. I was able to get away with 2 doses per day as a first-line agent for dialysis patients, and also have concentrated on those who have not been able to control their phosphorus well. So, in 2 or 3 patients, it was advantage when I had used this drug as a first line, and I was able to control the phosphorus well in them. So also the pill burden is less, and also the cost factor is one thing I think which over a period of time I think should come down further.
Professor Donald said about how this drug, if we start and then we continue, but some of us would be using it like we use aluminium, for example, for a short while to control the phosphorus and then stop. What is the general feeling? Should we start and stop, or should we just continue? What is the general feeling of what is practical for us in when there's cost constraints? What does everyone feel about that?
I think I would use it for quite some time until the serum phosphorus target is reached, and maybe I would opt to choose to another agent that is commonly used, like sevelamer or another cost-effective agent for that matter.
Dr. Mamin sir, you said about using it along with calcium acetate for those who have got hypocalcemia and hyperphosphatemia. Sir said about choosing calcitriol or a vitamin D analog along with this phosphate binder. What is general feeling? It's a little counterintuitive, right, to give a vitamin D analog when there's phosphorus is also high. So what do you, Dr. Mamin sir, what do you feel about that?
Like I've been using calcium acetate and this SFO rather than using vitamin D. Vitamin D we generally use once the phosphate levels have come down.
Yes.
Not otherwise. So that has been my strategy, though the experience is limited to about 20 patients or so far. And this combining with calcium acetate and SFO seems to be a better choice than vitamin D as of now. I don't know. We'll have to go up and see what the future results are like. How do you go about this, Santosh?
Sorry, sir.
How do you deal with such patients?
I would think that we should tackle the two separately. Giving the calcitriol when the phosphorus is high maybe actually counterproductive, I feel. Yeah, so I quite agree with you, sir. I have another question for all of us. When we switch from one drug to the other, do you take off the old phosphate binder or do we add it in a small dose? What is the general practice been? If somebody is already on sevelamer, like say 800 milligram 3 times a day, do we add a 500 of this, or do we take off the sevelamer, make it 400, and then do? What is the general practice been?
The number of patients I have tried this, actually I had stopped sevelamer and shifted. But the basic issue is GI upset is very, very difficult to control. Most of the patients, once we switch, complain of this. And some people even have this nausea, vomiting, which was actually not reported in the study. Study said only diarrhea. And sevelamer produced more of GI upsets. But probably we are not going to the tune of 800 milligram 8 hourly in most of our patients. That's why they are tolerating sevelamer better. But when you give 500 milligram 8 hourly, definitely the patient will have GI.
So you're saying stop the sevelamer and then give the SFO. Any concurrence or disagreement with Sir's suggestion?
No, I agree with Sir's suggestion. Remove everything because it's very potent. Stop other drugs, start SFOH alone, and then see how phosphorus control comes over a period of a month. And then in case required, they can add. Because main aim is to reduce the pill burden.
Yeah, that is very true.
Sir, I have a question to Dr. Santosh, if I am allowed. It's not about sucroferric oxyhydroxide, but there is a general guideline that now there is a paradigm shift. Like we are generally preferring non-calcium containing phosphate binder because of increased chance of vascular calcification. So in CMC, do you still use calcium carbonate and calcium acetate, or have you switched over to non-calcium containing phosphate binders?
That's a very loaded question for various things. So last time I think it was ISN or Southern chapter. I was doing a debate that I was speaking against calcium containing phosphate binders, and I think it was Southern chapter, yeah. And I was speaking against calcium containing phosphate binders, and sorry, it was ISN. ISN. Yeah, and my opposing person was speaking again for calcium. So basically, the literature, actually, all the literature is like about calcium carbonate, which we don't use. The little bit of data that is available for calcium acetate actually shows it in a favorable light. If you look at the data for calcium, it's when you combine all the data together, it shows that calcium is seen in a very poor light, whereas calcium acetate, the data is not that bad. It's actually not that bad. But coming back to your specific question, we use non-calcium based phosphate binders preferentially, but for those who have low calciums and those who've got financial constraints, we use calcium acetate, but not calcium carbonate.
Thank you.
I agree, Santosh. Basically, this is something like using sulfonylureas for controlling diabetes. In India, probably we'll have to continue using calcium-based phosphate binders for some more time, because the cost of the treatment is coming from the patient's pocket. So, well, you want to control the phosphate. That is the most important thing. And then if it can be satisfactorily done with a calcium acetate, fine.
But all said and done, actually, the data is like control of phosphorus. It's only observational data that control of phosphorus and reducing the phosphorus level is going to reduce mortality and morbidity. If that is the clinical hard endpoint which we are looking at. But it is only association. There is no causation which has been proved that elevated phosphorus level is going to make increase patient's mortality or morbidity. So whatever we are trying to do, we are just trying to treat numbers based on some observation data. There is no hard clinical data or randomized control trial to tell that a reduction in phosphorus level is going to make difference in patient's outcomes. Reduction in the phosphorus level and seeing that calcium, there is no calcification in the patient is only a soft endpoint which has been which we are focusing. In the end, does it really make a difference in patient's mortality and morbidity? Is not very clear. What do you tell, Santosh sir?
No, I completely agree with you. In fact, one more point that I wanted to add about that calcium debate is that one of the persons whose data was quoted for framing of the guideline which we are following, her data was debunked and her articles were taken withdrawn from publication, and she just about managed to keep her medical license. So there was a lot of publication research fraud in some of the data that is out there in this CKD MPD research. And so without divulging any names, it's all there they're out. So to look at all this, some of the stuff with a pinch of salt, we have to use what's most pragmatic for our population. Do we have any more experience to suggest or to share about the use of this and or an advantage so that we can all reach some kind of be on the same page about this new drug?
To summarize, primarily diet control should be the focus to control phosphorus level. Second, after we have exhausted the diet control options, we have to fall back upon non-calcium based phosphate binder in case the patient is affording. Try calcium based phosphate binders in patients who cannot afford and in whom calcium is low. Probably these three would be the basis for managing hyperphosphatemia in patients with CKD on dialysis.
And would I be right in saying that most of us feel that this drug could be used either as a de novo or in patients, in those who can afford, or as a substitute for other drugs in those who have difficult to control hyperphosphatemia? In either of these situations, we could use it depending on our clinical viewpoint in that particular patient. Would I be right in saying that would be what we feel?
That would be right. I think.
Yes.
Yes, sir. Completely agree.
So I don't have anything more to suggest or add. If anyone has anything to add to our discussion, otherwise it's been a good lecture that we've had from Dr. Donald. I think it was very good to listen to 45 minutes of all the data that's available on the drug. I think that was the highlight of this evening's thing. At one snapshot, we've got everything we wanted. It could have been, a few hours of reading the journal articles wouldn't have given us so much information. So for that, I thank the organizers for calling us for this meeting.
Thank you so much, Santosh sir, for moderating today's session, and all the panel members who have taken their time and joined. I'm sure that listening to Professor Donald Moloney was a wonderful experience, and there are certain key messages which we have just summarized now. So with this, I would like to thank each one of you for joining us today evening, and we will keep you posted with upcoming scientific meetings where we can add value to you and your clinical practice. Thank you so much, and have a nice weekend ahead. Thank you so much.
Thank you.
Thank you. Good night and have a nice weekend. God bless. Stay safe.
Thank you. Thank you. Bye.
Thank you. Bye.